Hello everyone, welcome to PW Method. I'm Dr. Patil and welcome to this Das Ka Dam series where we are trying to focus on 10 important concepts, topics or images for the upcoming NEET PG exam. If you're not getting into the details or conceptual understanding, we are creating hacks for quickly solving the important MCQs in the upcoming exam. So what we will do today is we will take up 10 important topics. We will see how to dissect the clinically oriented questions coming from these 10 important topics. Then we will go through 10 important images, primarily focusing on how to quickly recognize those images, and then 10 important one-liner MCQ points. So let me start with the first topic without wasting much of your time. Okay, so here is topic number 1, headache, a repeatedly asked MCQ topic. Multiple questions have been asked on headache. Almost every alternate exam, there is one question on headache. So that's the topic. Most of the headache question go somewhat like this, right? Generally they mention the age of the person, gender sometimes, and then the nature of the headache. You need to get on to the details of the nature of the headache to recognize which type of headache it is, right? So let me read this question for you. Here we have a 35-year-old who presented with episodic headache since few months. She reports that headaches are unilateral. So whenever it comes to headaches, laterality is the first most important point that you need to look into the question, whether it is unilateral or bilateral. Second thing is the duration of untreated episodes, and third, important clues by the examiners. So here it is unilateral. It is usually accompanied by redness of the eyes on the affected side and excessive tearing, means lacrimation. Each episode of headache lasts for around 10 to 15 minutes. 10 to 15 minutes on an average. What is the most likely diagnosis? So Tramadol thinks this is cluster headache, Rahul Singh thinks it is cluster headache, Random thinks is saying this is option E, paroxysmal hemicrania, right? So let us look at how do we approach such cases. Whenever you read a headache related question, rule number 1, try to rule out the secondary headaches. So whenever we have a question on headache, first thing is rule out the secondary headache. How do you rule out the secondary headache? By looking at what we call as red flag signs. Most of the questions, if it is a secondary headache, they will mention the presence or absence of the red flag signs, right? Rule out secondary headache by ruling out red flag signs. The red flag signs are those which suggest that it could be because of meningitis, it could be because of intracranial bleed, right? So mainly look for signs of raised intracranial tension and presence of fever, neck stiffness. If the question says patient has got fever, neck stiffness, we know it is meningitis. If the question says that patient has got bradycardia, hypertension, right, or any other signs or like projectile vomiting, the signs of raised intracranial tension, that means it is having a secondary headache. Once you rule out the red flag signs, then it is a primary headache disorder. After that, the first and the most important thing is you should see whether the headache is unilateral or bilateral. If it is bilateral, then a bilateral primary headache can only be tension type of headache. Tension type of headache. But if it is unilateral, right, it can either be migraine or it can be trigeminal autonomic cephalgias. Under that we have cluster headache, and apart from that we have paroxysmal hemicrania under this, paroxysmal hemicrania, and we have Sankt or Suna, right? These are the three important trigeminal autonomic cephalgias. Okay, clear? So when we look at this question, as soon as I read that this is unilateral and in the question there is nothing suggestive of a secondary headache, right? They are not saying that patient has got fever, neck stiffness, loss of consciousness, focal neurological deficits, raised intracranial tension, nothing of that sort. So I'm already thinking that this is primary, and then once I notice that it is unilateral, the tension type of headache is ruled out. Okay. There is an entity called as medication overuse headache, which is repeatedly asked recent times, but in that case, in the question only they will mention that headache usually gets better on stopping the painkillers. So whenever a question says that headache got better on stopping the painkillers, then it is medication overuse headache. Headache gets better on stopping painkillers. Then you have a medication overuse headache. So such history is not there here, so that is also ruled out. Okay, so now we are left with primarily the unilateral primary headaches, which is migraine, cluster headache, paroxysmal hemicrania, and Sankt or Suna. How do we differentiate between these three? It is based on the duration of untreated episode of headaches. That is why duration is the second most important thing. So when it comes to migraine, right, migraine lasts for around 4 to 72 hours if not treated. Trigeminal autonomic cephalgias generally last for less than 4 hours. So unilateral primary headache lasting for less than 4 hours can be cluster, paroxysmal or Sankt or Suna. Can't be migraine. Cluster headache usually lasts for 30 to 180 minutes. Paroxysmal hemicrania usually 15 to 30 minutes. And Sankt or Suna 4 to 240 seconds. Or in simple words, 4 seconds to 4 minutes. So with this backdrop, when we go back to the question, right, we can clearly notice that in this question, the episodes are lasting for 10 to 15 minutes. So now what is our diagnosis? Should we revise our diagnosis? Should we revise our diagnosis? Yes. So when I say 10 to 15 minutes, it mostly closely fits into paroxysmal hemicrania, right, in terms of duration. If it was cluster headache, it should last for more than 30 minutes, up to 3 hours. So that makes it most likely a case of paroxysmal hemicrania. So I hope the approach is simple, right? Look at unilateral or bilateral. After that, look at the duration of untreated episodes. Apart from that, there will be some additional clues given by the examiners. So we will go through that. Tension type of headache is usually in the question they mention that there are stressors present. Patient is going through some stress, like a breakup or financial loss of job, right? Something like that. Second option is absolutely correct. Yeah. Stresses. Second thing they will mention is the headache is usually described as vice-like grip or band-like sensation. Band-like sensation. So whenever you see these words, then you know that the question is talking about tension type of headache, right? If it is a case of migraine, generally they will mention photophobia or phonophobia, nausea or vomiting, and maybe even presence of aura. So if these features are there, then you know that this is a case of migraine. Okay. Cluster headache and paroxysmal hemicrania, because both of them are trigeminal autonomic cephalgias. The word autonomic comes from the presence of autonomic symptoms. So these two conditions will often have redness of eyes, along with that increased lacrimation and nasal stuffiness. If these are mentioned, that means the question is talking about one of the so-called trigeminal autonomic cephalgias. Okay. Additional clues for paroxysmal hemicrania, there will be excellent response to indomethacin. So whenever a question says that a patient showed excellent response to indomethacin, the examiner is directly telling you I am talking about paroxysmal hemicrania. And in cluster headache, usually they mention 2 points. One is seasonal variation and the second one is alcohol. There is a relationship with alcohol with cluster headache. So if the examiner says alcohol is precipitating the headaches, then it is again pointing towards cluster headache. And if it is occurring in a particular season, then again it is talking about cluster headache. Clear? So that is our approach to headache, and that is our topic number 1. Any question with headache? First thing, rule out the secondary headache. So please look for the signs of raised intracranial tension, fever and other causes for secondary headache. Second thing, if there is history saying that on stopping the medications headache got better, then take it as medication overuse headache. If these things are ruled out, then look at whether it is unilateral or bilateral. Bilateral, tension type of headache. Unilateral, migraine or tax. To differentiate between migraine or tax, look for these clues that we have listed and look for the duration of untreated episodes. Migraine 4 to 72 hours, cluster headache 30 to 180 minutes, paroxysmal hemicrania usually less than 30 minutes, 15 to 30 minutes is the average range, and Sankt or Suna few seconds. Clear? Okay. Now coming to the next topic, which is again a valvular heart disease. And I'm not getting into the details of valvular heart disease. This will take an entire day for us to understand valvular heart disease in succinct detail. What we are going to do now is to get a essence, right? Try to learn how to quickly dissect a valvular heart disease question to come out with the diagnosis. So I will give you again 3 or 4 simple steps for us to reach the final diagnosis. Okay, so here is a question. A 55-year-old presented with raised JVP tender and pulsatile hepatomegaly, ascites and pedal edema. On auscultation, patient had a pansystolic murmur, best heard in the left lower parasternal region. The murmur accentuated on inspiration. What is the most likely diagnosis? Okay, so what do you think is the diagnosis here? Generally, these kind of questions talk about set of symptoms, right? This question has an anatomy. What are the anatomical parts of a question? The question will say some points about the symptoms, right? And then it will mention the auscultation findings, basically the nature of the murmur, right? And then within the auscultation finding or the nature of the murmur, they will also mention usually the relationship of the murmur with the phase of respiration, whether it gets better on expiration or whether it gets better on inspiration, and that will help us to reach the diagnosis. Okay, now just look at the first set, that is symptoms. What do you think? The patient's symptoms are suggestive of a pathology affecting the right side of the heart or the left side of the heart. That's our step number 1. Is it pathology affecting the right side of the heart or the left side of the heart? See, when we look at the circulation, we know that the superior and inferior venae cava drain their blood into the right atrium. From there, the blood goes to the right ventricle, right? And from the right ventricle, blood goes to the lungs through pulmonary artery, right? And from the lungs, the oxygenated blood comes to the left atrium through what we call as pulmonary veins. And once it comes to left atrium, from the left atrium, blood goes to the left ventricle. And from the left ventricle, we eject that blood into the aorta. Okay, so if I have a problem in, let me say, tricuspid valve or pulmonic valve, that means I am having a right heart dysfunction. If I have a problem in mitral valve or the aortic valve, I am having the left heart dysfunction. So please remember, if I have a problem in tricuspid valve or the pulmonic valve, the final outcome is pressure inside the right atrium increases. So whenever I have a dysfunction of the left side of the heart, the final outcome is the pressure in the left atrium increases. So whenever pressure in the left atrium increases, it leads to congestion of blood in the lungs. Means right side of the heart pushes the blood into the lungs, but it can't come to the left side of the heart easily because pressure in the left atrium is already high. So then the blood starts getting stagnated in the lungs. So left heart dysfunction leads to congestion of the lungs. What symptom it should give rise to? Shortness of breath, right? Dyspnea, orthopnea, PND. If I have a dysfunction of the right side of the heart, the pressure in the right atrium increases. So that leads to congestion in the veins which are draining into the right atrium. So I can have rise in the JVP. And second, if the pressure in the inferior vena cava rises, then because the blood from the liver drains through hepatic veins into the inferior vena cava, we will have congestion in the liver, and all the fluid draining from the lower limbs also gets impaired. So we can have pedal edema and ascites. So first thing when we see a question on valvular heart disease is to understand whether we have a right heart dysfunction or left heart dysfunction. So right heart dysfunction leads to rise in JVP, raised JVP, okay, then hepatomegaly, ascites and pedal edema, ascites and pedal edema. And when we have left heart dysfunction, primarily the congestion is happening in the lungs instead of liver and veins, so we will get dyspnea with more specific orthopnea and PND. Dyspnea, orthopnea and PND. So that is the first step, right? Try to identify whether the dysfunction is affecting left side of the heart or the right side of the heart. So now going back to the question, right? What is it affecting? When we look at the symptoms, we clearly know that it is a right heart disorder. That means the problem must be in the tricuspid valve or a pulmonic valve if it is a valvular heart disease, right? Because there is raised JVP, hepatomegaly, ascites and pedal edema, all pointing towards right heart dysfunction. Okay. Then the second clue that the examiner generally mentions is the nature of the murmur and where is it best heard. Even if you don't know what murmur I am supposed to hear in a particular condition, you have to primarily focus on where is it best heard. So here they have mentioned that it is best heard in the left lower parasternal region. So this region is the surrogate region for a particular valve. So once you know the auscultation areas, you know the murmur is best heard from which area, right? So now tell me which area this is representing. Is it the mitral area, tricuspid area, aortic area, or pulmonic area? Left lower parasternal region. From the symptoms, I understand that patient has got right heart dysfunction, so I'm already suspecting that he may be having pulmonic valve or the tricuspid valve pathology. Now I have heard a murmur, forget about the nature, pansystolic, diastolic. This murmur is best heard in the left lower parasternal region, which is the tricuspid area, right? Which is a tricuspid area. So that clearly tells me that the pathology has to be in the tricuspid valve, right? So that is why we need to remember the areas. On the right side, we have only one area, which is aortic area, that is right second intercostal space, right? Rest of the areas are on the left side. On the left side, first intercostal space is Gibson's area, which is used for the auscultation of murmur of patent ductus arteriosus. Second left intercostal space is the pulmonic area, where we will hear a murmur if there is a pulmonic valve pathology. Then third left intercostal space is Erb's area, which is also called as neo-aortic area, where you can hear murmurs of aortic valve pathology. Then lower left parasternal region is the tricuspid area. That is where we are hearing the murmur in this question. So that means whatever is the pathology, it is affecting the tricuspid valve, right? And then mitral area is where we have the apex. So from this information, I can conclude that the pathology is in the tricuspid valve. Right now, I don't know which murmur we get in tricuspid stenosis and which murmur we get in tricuspid regurgitation. But from the information, I know that patient has got a right heart dysfunction and it is affecting the tricuspid valve. Quickly look into the options. Many a times the diagnosis is straightforward, clear there itself. So there is only one option of tricuspid pathology, that is tricuspid regurgitation, and I will mark that. But if I am in doubt, like there are options of tricuspid stenosis as well as tricuspid regurgitation, then only I need to know the murmur, right? So please remember, the murmur of tricuspid stenosis is a mid-diastolic murmur. Murmur of tricuspid regurgitation is a pan-systolic murmur. Again, one more important clue. If you remember the murmurs of 4 valvular regions on the left, you can extrapolate it to right. Okay, I will give that in writing to you. But for now, we will mark this answer as option D based on our approach from symptoms and the area where the murmur is best heard. Many times in the exam, they mention the murmur's relationship with respiration. So please remember, the murmurs originating from the right side of the heart, that is pulmonic valve or tricuspid valve, become increased in intensity during inspiration, and murmurs originating from the left side of the heart increase in intensity during expiration. So if I hear a murmur better in expiration, then it may be an aortic valve pathology or a mitral valve pathology. If I better hear it in the inspiration, it has to be a pulmonic valve or the tricuspid valve pathology, right? So those are the extra points that we need to know here. This is one thing. Second, right-sided murmurs increase on inspiration, and left-sided murmurs increase on expiration. Left-sided murmurs increase on expiration. So this will also help you to identify whether it is a right heart pathology or left heart pathology. Only the last thing I want you to do is be aware of the murmurs. Many a times, even if you're not aware of the murmurs, you will be able to recognize. So when I say aortic stenosis and pulmonic stenosis, both of them will have the same murmur, which is ejection systolic murmur. Ejection systolic murmur. Usually it will be abbreviated. You will get a phonocardiographic image sometimes. When you say ejection systolic murmur, the murmur starts once the systole starts. The ejection phase of the systole starts, and it is a crescendo decrescendo murmur or a diamond shaped murmur heard between the S1 and S2, starting somewhere in the middle of the systole. That is what you get in aortic stenosis and pulmonic stenosis. Okay. In case of aortic regurgitation and pulmonic regurgitation, you get the early diastolic murmur. Early diastolic murmur. So obviously diastole happens between S2 and S1, right? This is my S2, this is S1. So when I say early diastolic murmur, only in the initial phase of the diastole. that is our aortic regurgitation and pulmonic regurgitation murmur. Okay, mitral stenosis and tricuspid stenosis, we have the same murmur, which is mid diastolic murmur. So it starts in the middle of the diastole. So this is my S2, this is my S1, that is where the diastole is happening, right? So murmur starts in the middle of the diastole, and then the murmur typically has a pre-systolic accentuation, slightly increases in intensity before the next systole starts. This is S1, this is S2. Okay, now what are we left with? We are only left with mitral regurgitation and tricuspid regurgitation, MR and TR. In both cases we get a pansystolic murmur. Pansystolic murmur means it happens between S1 and S2 and it runs from S1 all the way to S2. That's why it is called as pansystolic. So as long as you remember these four murmurs, these four phonocardiograms, you're set for answering most of the questions coming from the valvular heart diseases. So just remember this approach. Whenever you read a valvular heart disease questions, first decide whether symptoms are suggestive of a right-sided pathology or a left-sided pathology. If it is predominantly orthopnea, PND, shortness of breath, left-sided pathology. Predominantly raised JVP, hepatomegaly, ascites pedal edema, right-sided pathology, right? After that, look at the murmur, primarily focus on which area it is better heard. That area itself tells you from which valve this pathology is coming, this sound is coming from. You may have your answer then and there itself. If at all, if I had given this option of tricuspid stenosis also in this question, only then which type of murmur is seen in which valvular heart disease comes into picture. For that, for now, I want you to remember only these four things. Done. Okay. Now our next topic is on ABG. I think almost every NEET PG exam has one question on ABG. Okay, most of the questions are simple, but sometimes they can make it a bit tricky. So here is a question. Interpret the following ABG and tell me whether it is normal or whether patient has got an ABG abnormality. The pH on this ABG is 7.38, PaO2 is 76, PaCO2 is 82 and bicarb is 31. So what do you think? Is this a normal ABG or abnormal? Okay, how many of you think this is a normal ABG? Or how many of you think this is abnormal? And if it is abnormal, what should be our answer? Normal metabolic acidosis, respiratory acidosis, metabolic alkalosis. Okay. Okay, so simple. See, you will call an ABG as completely normal when three parameters are normal. What are those? pH, PaO2, PaCO2, bicarb, 4. Okay, PaO2 is mainly for respiratory failure. Otherwise, pH, PaCO2 and bicarb. If all three are normal, then it is a normal ABG. Merely having a pH normal does not make it as a normal ABG, right? Now here, what is the pH? Is it normal or abnormal? Is it normal or abnormal? Is it normal or abnormal? Okay. So please remember, when we interpret ABG, right, the first thing we will look at is the pH. pH, right? What is the normal pH? The normal pH ranges from 7.35 to 7.45. 7.35 to 7.45. That is a normal range. If the pH is less than 7.35, then that means pH is low. We will call that condition as acidosis. Whether respiratory metabolic, we will look into it later. And if the pH is more than 7.45, we call it as alkalosis. Alkalosis. That's a pretty simple approach, right? And once we have decided whether it is acidosis or alkalosis, next step is to decide whatever is the pathology, whether it is metabolic or respiratory, right? So for that, we will follow so step 1 is to look at the pH to decide acidosis or alkalosis. Now step 2 is to decide whether it is metabolic or respiratory, right? In step 1, we decided whether it is acidosis or alkalosis based on the pH. In step 2, we will decide whether the pathology is metabolic or respiratory. For that, we have a simple technique which is ROMS method or ROMS mnemonic. What ROMS stands for? ROMS stands for respiratory opposite metabolic same or same side. So for that, what we need to do is look at the pH and the PaCO2, right? Look at the pH and PaCO2 and then plot their direction, whether they are increasing or whether they are decreasing. Okay, pH we know the range. I will also give you the range of PaCO2, right? PaCO2, what is the normal range? The normal range is from 35 to 45 millimeters of mercury. That is the normal range of the PaCO2, partial pressure of carbon dioxide. Okay. For time being, just ignore this pH 7.38. Let us presume that this is 7.2. Okay, I'll come back to this 7.38, this ABG, but for time being, let us take the same ABG, but make the pH as 7.2. Okay. Now, if the pH is 7.2 for this example, and then PaCO2 is 82. PaCO2 is 82, right? So, in comparison to normal pH, whether this pH is decreased or increased? Decreased or increased? Normal is 7.35 to 45. So, that means it is decreased, right? Compared to normal PaCO2, this PaCO2 is decreased, normal or increased? It is increased, right? So, all you need to do is plot it. Plot it. So, once we plot it, right? Once we plot the directions, we have to see whether the directions are following, they are in the same direction or they are in the opposite direction. So, if they are in the same direction, metabolic, same, metabolic, same. So, if pH is decreasing, PaCO2 is also decreasing, then I would label this condition as a metabolic pathology. Okay. But when they are in the opposite direction, right, pH is decreasing, PaCO2 is increasing, or the vice versa. pH is increased, PaCO2 is decreased. So, when they are in the opposite direction, the pathology will be counted as respiratory. So, now going back to this ABG, if I keep the number of pH as 7.2 and the rest of the things same, applying the previous method that we followed, right? First, looking at the pH, we come to the conclusion that this is acidosis. After that, we look at the PaCO2 and pH. So, if pH is decreased, PaCO2 is increased. So, both are in the opposite direction. So, I will label it as respiratory. Respiratory opposite, metabolic same, ROMS, right? So, then the diagnosis becomes respiratory acidosis. That would have been a simple ABG. But in this case, the pH is normal. So then does that become the ABG normal or is the ABG abnormal? For that, we need to just spend few more minutes understanding how body regulates the acid-base balance. See, in the body, the most important acidic ion is going to be carbonic acid, which is derived from carbon dioxide. So I can say carbon dioxide, if it increases, the acid level in the body increases. Okay, carbon dioxide, if it decreases, the acid level in the body decreases, right? Because when water dissolves, when carbon dioxide dissolves in water, it becomes carbonic acid, and then our bicarbonate, right? Bicarbonate is the most important buffer for this acid, or in other words, I would say this is the most important base, right? This is our most important base and this is our most important acid. Normally their levels balance in such a way that the pH is kept in the range of 7.35 to 7.45. Okay, so now you tell me, if I decrease the bicarbonate, then what should happen to the carbon dioxide? To maintain the pH in this normal range, should I decrease the carbon dioxide or increase the carbon dioxide? See, normally both of them are at some level and because of that pH is maintained at the normal level. So if I decrease the base to keep the pH still in the normal range, should I decrease the acid or should I increase the acid? My base is decreased, right? The basic component is decreased. Now I have more acid. So should I decrease the acid? Yes. So please remember, if the primary pathology is 1, the compensatory mechanism will also follow the same direction. So if the base is decreased, the acid should decrease, right? If the base is increased, the acid should increase, or the vice versa. If the acid is decreased, the base should decrease, right? So in respiratory acidosis, the previous example that we saw, what happens? We are not able to clear the carbon dioxide. We are retaining the carbon dioxide in the lungs, right? In the respiratory system, we are retaining it in the blood because we are not able to clear it, like we have COPD. So acid is increasing. So if the acid is increasing, the base is expected to increase. So if base increases, that means the metabolic system or the kidneys are compensating. That is a compensatory change. If the compensatory change is strong enough to get the pH back to normal. See, to give you an example, I added too much of carbon dioxide. Because I have COPD. Because of the increasing carbon dioxide, acid is increasing, so the pH has a tendency to drop. So let me say pH has become 7.2. Right? Now to compensate for that, the bicarbonate will drop. Once the bicarbonate drops, if the pH goes back to the normal range, then we will say fully compensated. Right? So when base decreases, it is compensation, and if the compensation is strong enough to push the pH back to normalcy, we will call it as fully compensated. So now getting back to this ABG, pH appears to be normal, right, in the normal range, but PaCO2 appears to be increased and bicarbonate also increased. Normal is 22 to 26 millimoles per liter, so that also is increased. So as we know that if acid is increasing, the base will also increase. So compensation is happening, and compensation has efficiently put the pH back to the normal range. So that makes it as a fully compensated respiratory acidosis. So this patient has got fully compensated respiratory acidosis. If I give the same ABG but mention the pH as 7.2, then it will become partially compensated respiratory acidosis. Why partially? Because the pH is not corrected. pH is still low. But why do I say that there is compensation happening? Because the bicarb has increased following the increase in the PaCO2. But if I change this and mention that the PaCO2 bicarb is, let me say, 22 only in the normal range, then we will call it as an uncompensated respiratory acidosis. Now the real confusion on these questions is, if the pH is normal, how will I interpret the first test itself, the step 1 itself? See, we have three things to look at. One is, first decide whether it is acidosis or alkalosis. Then decide whether it is metabolic or respiratory. For that we have this ROMS. Third, decide whether it is fully compensated, partially compensated or uncompensated, looking at the pH, right? If the pH is in the normal range, then it is fully compensated. If pH is not back to normal range, then it is partially compensated, provided the compensatory change is happening. No compensatory change at all, then it is uncompensated. But the first step only will be impaired if my pH is already normal, right? So then how will I decide whether it is acidosis or alkalosis? So please remember, whenever we have to interpret such ABGs, right? So instead of taking the full range as normal, use the middle ground, that is 7.4. So whenever you have a fully compensated ABG, see, this ABG all of us agreed that it is not normal because the internal components of the ABG are abnormal. Both the base and acid are increased here. So this is not a normal ABG for sure. So once you decide that this is not normal ABG, then to understand whether it is acidosis or alkalosis in such pictures, use the 7.4 as the middle ground. So if the pH is less than 7.4, then it is acidosis, and if the pH is more than 7.4, then it is alkalosis, right? So I will give you one more example now. You should tell me what is it. So pH of this person is 7.42. Okay. PaCO2 is 10 millimeters of mercury, and bicarb is 12 millimeters of mercury. So now interpret this ABG. Is it normal? It is not, right? Because both PaCO2 and bicarb are abnormal. They are abnormal. So then it is having an acid-base disorder. By looking at the pH, all of us now clearly know that this is a fully compensated acid-base disorder. Now we have to understand what acid-base disorder it is. Right, so using 7.4 as the cutoff, it becomes alkalosis. So step number 1 done, it is alkalosis. Right, now what is our step number 2? Applying ROMS, right? So here PaCO2 is decreased, bicarbonate is also decreased, and pH is increased. So when you apply for the ROMS, we are looking at PaCO2 and pH, right? Are they following the same direction or opposite direction? Are they following the same direction or opposite direction? They are following in the opposite direction, right? So that makes it as a case of respiratory. So here we have a respiratory alkalosis which is fully compensated, What is the compensatory mechanism here? The primary pathology is washing out of carbon dioxide. The compensatory mechanism is because acid is decreasing, as a compensation we have decreased the base also. Okay, so ABG is our one more important topic. Okay, now we will move to the next topic, which is again an examiner's favorite, that is the AV blocks and arrhythmias. Okay, so here is a question. A patient with an episode of syncope following ECG is suggestive of. Okay, so just go through the ECG and tell me what do you find here. Parmendra Singh, to call it as acidosis, the pH should be less than 7.4 in a fully compensated picture. Less than 7.4 we will call it as acidosis. More than 7.4 we will count it as alkalosis. Okay, can this be, let me ask the first question, can this be ventricular tachycardia? The answer is no, because we don't see tachycardia here, right? Rather the patient has got bradycardia. When you look at here, the heart rate is definitely not more than 100. So this is a bradycardia. So we have to think of a AV block or SA block. Okay, so ventricular tachycardia is something that we can confidently rule out. Remaining options, right? First degree AV block, SA block and second degree AV block. Now before I go to AV blocks, what is this SA block? SA block means the block is, see, we know that the pacing of the heart is done by SA node, right? SA node acts as our pacemaker. From there the impulses reach through the internodal pathways to AV node, and then AV node hands it over to the His bundle, its right and left branches, Purkinje fibers, and then we end up depolarizing the ventricle. Okay, so when there is a block of transfer of the wave generated by SA node to AV node, means AV node is not receiving the electrical impulse, that is our AV block, right? SA block is where SA node initiates an impulse but it fails to exit the SA node itself, then we call it as SA block. How do we identify an SA block? See, if SA node is acting as a pacemaker, then it will send the electrical impulses to depolarize the atria and we will have a P wave. But if SA node starts an electrical impulse but the impulse does not exit the SA node at all, then will we have a P wave? No, right? So in the ECG, in SA block, you will have absent P waves. So in this ECG, we can clearly see multiple P waves. There are no absent P waves. So that comfortably rules out the possibility of an SA block. In AV block, what happens? SA node starts an electrical impulse, right? It goes on and depolarizes the atria. So we will definitely have P waves. But because it is not reaching the AV node, if it fails to reach the AV node, then I will not be able to depolarize the ventricle and I can have missed or absent QRS. So if I have a missed or absent QRS, then I would think of AV block. If I have missed or absent P waves, then I would think of SA block. So in this question, definitely P waves are there. There are no missed P waves. So SA block is ruled out. We are mainly left with AV blocks. Okay. So then we know that there are different grades of AV block. The first degree AV block is where the PR interval is prolonged, but there are no missed QRS. So first degree AV block is prolonged PR interval, but no missed QRS. Why is that happening? Because here normally when SA node sends an electrical impulse to AV node, the AV node holds on to it for a fraction of a second before handing it over to the His bundle to cause the ventricular depolarization. This is very much required because when atria is in systole and contracting to push the blood into the ventricle also should not be simultaneously contracting. It should be in diastole to receive that blood, right? So to create this break of systole and the diastole of the two chambers, AV node plays an important role, right? It introduces what is called as AV nodal delay. Okay, and that is why we have this PR interval. If there is no delay, P will be followed by quickly QRS complex. Okay, Now if unfortunately AV node holds on to that electrical impulse for more than required time and then hands it over without fail but taking longer time, then we get this first degree AV block. And because AV node is holding on to the impulse for a longer time, the PR interval becomes prolonged. Okay, so that begs the question, what is the normal PR interval? What is the normal PR interval? Normal PR interval is, so please remember, normal PR interval is 120 to 200 milliseconds. So when I say 120 to 200 milliseconds, that means 3 to 5 small squares on the ECG. 3 to 5 small squares on the ECG. One small square on the ECG is equal to 40 milliseconds. So when you say that from the PR interval is taking more than 5 small square, it means you have the first degree AV block. First degree AV block. Okay. Now then it also begs one more basic question. I will mark you 2 points. You should tell me which one of them represents the PR interval. Okay, so this is one in blue color and then I have one more in red color. Which one is representing the PR interval? One in blue color or one in red color? Ankit, more than 5 small squares. If the PR interval is taking more than 5 small square, that means it is prolonged. Which one is the PR interval? Okay, so Ankit and your drug of choice, absolutely right. So please remember one more important statement today. Whenever in the ECG we say intervals, intervals means within that there will be a wave. And when you say segment, right, like ST segment, PR segment, TP segment, segments do not have a wave. So whatever we have here between red lines is the PR segment, and whatever we have between these blue lines means from the beginning of P wave to the beginning of QRS complex, that is our PR interval. So interval always includes a wave. For example, you have this QT interval, right? So that starts with the beginning of the Q wave to the end of the T wave. That is our QT interval. I think in one of the previous sessions we were talking about QT prolongation leading to tau series D pointers. That means this is prolonged. This QT interval is prolonged. So interval always includes a wave, segment never includes a wave. So this is ST segment, right? End of the S wave to the beginning of T wave is ST segment. End of the T wave to the beginning of the P wave is the TP segment. Segments do not include a wave. So this from the beginning of P to the beginning of the QRS, if it is more than 5 small squares, that means PR interval is prolonged. So if there is prolonged PR interval but no missed QRS, it is first degree AV block. Okay. Now this first degree AV block is benign and it does not require treatment, right? It is safe, or in other words benign, and there is no treatment required. All you need to do is tell the patient you're fine, no need to worry about it. Reassurance. Okay. Then we have second degree AV blocks. Second degree AV blocks, we have 2 types. The first one is called as Mobitz type 1, which is very dramatic, as you know. In Mobitz type 1, there is serial prolongation of PR interval till a missed QRS. Serial prolongation of PR interval till a missed QRS. And this cycle goes on repeating. As you see in this ECG, you can clearly notice, right? I will just quickly mark the PR interval and you can notice it. This is a PR interval in the first complex. This is a PR interval in the second. This is a PR interval in the third, right? So as you trace from one beat to the next beat, you will notice that serially PR interval is increasing, right? So here it is barely 5 small square. It becomes 6 small square. It becomes 7 small square. So it is increasing till you encounter a point where you will have a P wave, but QRS goes missing. QRS goes missing. This is what we call as Mobitz type 1, second degree AV block Mobitz type 1, which is also known as 𝐒𝐿𝐄𝐝 phenomenon, right? Which is also known as 𝐒𝐿𝐄𝐝 phenomenon. Okay. Now, how do we treat these patients? This is also benign or safe, generally not needed to treat. So we treat these patients only if symptomatic. If they're not symptomatic, there is no need for treatment for the Mobitz type 1. Then we have this Mobitz type 2. Mobitz type 2. What happens, or how is it different from Mobitz type 1? In Mobitz type 1, the PR interval kept on increasing till it failed to conduct to the His bundle, giving rise to a dropped QRS. That is Mobis type 1. In Mobis type 2, there will be dropped QRS, but without serial prolongation of the PR interval. So here you will have constant PR interval, but intermittently missed QRSs. Intermittently missed QRS. As you see in this image, you can see that the PR interval is constant throughout, right? But then I have a P here and there is no QRS. Constant PR interval with intermittently missed QRS. That is our Mobis type 2. Okay. Then we have a third degree heart block. Third degree AV block is also called as complete heart block. So in these patients there is AV dissociation. There is AV dissociation. Now what is the meaning of AV dissociation? See, normally when atria goes into systole, ventricle will be in diastole, right? So that is why when atria is in systole, we get a P wave. Then ventricle at that time will be in diastole. Later it goes into systole. At that time we get a QRS. So whenever you take a normal ECG, a P will be followed by a QRS, then again a P, then again a QRS. This is a beautiful relationship that ventricle and atria share. But if they get divorced, they start beating on their own. So in that case, a P followed by QRS relationship will be lost. So you will have a picture like a QRS, right? Again a QRS, then maybe a P, then again a QRS, then a P, a QRS. So you can't say that a P is always followed by a QRS that we get in a normal condition. So when this P followed by a QRS relationship is lost, we call it as the third degree AV block or AV dissociation. Like you see in this ECG. Here you can get a P wave, right? Here I get a QRS. This is the T, and in between I have a P wave. So QRS followed by P wave. Again a P followed by QRS. This is T and then P, right? P followed by a P and then a QRS. So we don't have this relationship of P followed by QRS, again P followed by QRS, a P followed by QRS. That is distorted or lost. This is what we call as third degree AV block or AV dissociation. Now this Mobis type 2 generally progresses to third degree AV block quickly. That is why Mobis type 2 and AV dissociation or the third degree AV block, right? Both need to be treated. Treatment needed for both. Treatment needed for both. Okay. Then if we are treating for the AV blocks, what is the drug of choice? What is the drug of choice if the treatment are needed for AV block? So whenever we treat AV blocks, right? AV block treatment, the first line of management is going to be atropine. First line, or in other words, the drug of choice is going to be atropine, because we know atropine increases the heart rate. So basically on the essay note, we have sympathetic and parasympathetic nervous system acting on it. Right? Sympathetic stimulates it, parasympathetic inhibits it. So if I block the parasympathetic nervous system, the inhibition is gone and the heart rate will get increased, right? So that is why atropine will become the first line management. If we are not able to get the heart rate normalized with atropine, then what can we do? We have tried one, right? We have tried to inhibit the parasympathetic. Now we can stimulate the sympathetic with the use of adrenaline or noradrenaline. Adrenaline, noradrenaline or dopamine can be used, but these are temporary measures. Most of the times patients develop what we call as tachyphylaxis. What is a tachyphylaxis? You give some drugs, system get used to it and the drug fails to work efficiently over time. So if the underlying condition responsible for heart block is incurable or a long-standing disorder, in that case these temporary measures will not be useful for the long term. So in such cases, what we do as a third line, we go for what is called as pacemaker. So we might have to consider putting the pacemaker to the patient. Okay. So AV blocks is an important topic for us. Now from AV blocks, we will go to the next topic, which is tachyarrhythmias. AV blocks primarily present as a bradycardia or bradyarrhythmia. When you have a block, obviously heart rate will not be high. Okay. So here is a question. A patient collapsed suddenly. He was unresponsive and pulse was not felt. Following ECG was recorded. What is the next best step in the management? Okay. I will give you an option E also. So what ECG shows and what is our diagnosis? So guys, please remember, whenever you think of blocks, right, whether it is SA block or AV block, think of blocks only when patient has got bradycardia. When you have tachycardia, it can't be blocks. I can't have a heart rate of 150, 200 when I have a third degree heart block or a Mobis type 2 second degree heart block or a SA block. Because I think in physiology you have studied that every part of the conducting system is capable of being its own pacemaker but at a fixed rate, right? The SA node can initiate the impulse at 60 to 100, but when I come to AV node, its ability to initiate the rate is lower. When you go to His bundle, further lower. When you go to the bundle branches of Purkinje fibers, further lower. So that is why if I block SA node or AV node, heart rate invariably drops. Yes, this is VT, right? But what type of VT? We have three types of broad complex tachycardias. So whenever approach to tachyarrhythmias is whenever you get a tachyarrhythmia, right, heart rate higher than 100 and you have some abnormal ECG appearances, you have to divide that into a narrow complex tachycardia and a broad complex tachycardia. Any arrhythmia patient, divide them into narrow complex and broad complex. So when I say complex, I am referring to the QRS complexes, right? So what is the normal QRS duration? Normal QRS duration is 80 to 100 milliseconds, right? Always less than 3 small squares, that is 120 milliseconds, always less than 3 small squares. So whenever it is more than 3 small square, it is broad. So whenever we have a case of tachyarrhythmia, we have to look at the QRS duration. That is our first step on the arrhythmia ECG. If it is more than 3 small squares, means QRS is taking more than 3 small squares, or in other words more than 120 milliseconds. We call those arrhythmias as wide complex tachyarrhythmias. And if it is less than 3 small squares, the QRS is taking less than 3 small squares, then it is a narrow complex tachyarrhythmia. What all narrow complex tachyarrhythmias we know? We know paroxysmal supraventricular tachycardia, right? We have atrial fibrillation. Then we have atrial tachycardias. Okay, within that atrial tachycardias, we have focal atrial tachycardia or FAT. We have multifocal atrial tachycardia, and we have atrial flutter. These are all narrow complex tachyarrhythmias. Okay, and then wide complex tachyarrhythmias, we have 3. What are those? One is ventricular fibrillation. Then we have polymorphic ventricular tachycardia, polymorphic VT, and then we have monomorphic VT. So we need to learn to identify these, right? So I will give you some clues to quickly identify those abnormalities. So first thing is, in PSVT and atrial fibrillation, right, you will have absent P waves. In atrial tachycardia, right? So when I say atrial, that means atria is getting depolarized. As long as atria is getting depolarized, we will have P waves, right? But atria is beating faster than the ventricle. So then what will happen to the number of P waves versus the number of QRS complexes? If atria is beating faster than the ventricles, means atria has more contractions than the ventricles, then what will happen? In such cases, in atrial tachycardias, the ground rule of atrial tachycardias is the number of P waves on the ECG will be more than the number of QRS complexes. More number of P waves than the QRS complexes. That means you have a atrial tachycardia. Okay. If all the P waves in a given ECG look same, they are more than the QRS but they look same, then we call it as focal atrial tachycardia. Just to give you an example, the ECG may be looking like this. Means I have a P wave and then a QRS complex, right? I have a P wave, and then a QRS complex. This is what we will call as focal atrial tachycardia. Why focal? Because the P waves are originating from the same source. Okay, but if I have different looking P waves, like one P wave is tall, okay, and then I have another P wave which is looking normal, then I have another P wave which is inverted, and then I have a QRS complexes. So if I have three different P waves, different morphologically looking P waves in a given ECG, then we call it as multifocal atrial tachycardia or MAT. Simple words. The P waves are looking different. They are originating from different sides of the atria. That's why it is called as multifocal atrial tachycardia. If the examiner gives you an image of multifocal atrial tachycardia, always they will put an arrow mark to those different looking P waves. That's your clue. Okay. Then atrial flutter is a form of atrial tachycardia where the number of P waves are so higher in comparison to QRS that the whole ECG starts looking like the sawtooth appearance. Means too many P waves, then one QRS complex. Too many P waves, and then one QRS complex. So now this looks like a sawtooth, right? That is what we call as atrial flutter. Atrial flutter. So in atrial flutter, multiple P waves are more than QRS, but too many P waves, not just 2-3 P waves and then a QRS, 6-7 P waves and then a QRS, again 6-7 P waves and then a QRS. Because of that, ECG starts looking like the sawtooth appearance. We call it as atrial flutter. So this appearance is also called as sawtooth appearance. Okay, now the question is how to differentiate between PSVT and atrial fibrillation, because in both the cases the QRS will be narrow and you will not have P waves. Then how do we differentiate between the two? Yes, Ankit, absolutely right. So PSVT, your RR interval will be regular, means constant, and in atrial fibrillation the RR interval will be varying. So that helps you to differentiate between PSVT and atrial fibrillation. Okay. Now how do I distinguish between these wide complex tachyarrhythmias? That is pretty simple. Okay. First thing is, if it is ventricular tachycardia, as we know, it could be monomorphic. When you say monomorphic, that means the tachycardia is originating from one focus in the ventricle. So because of that, all the QRS complexes in a lead will look same. They look same. They are not different. Then we call it as monomorphic. We will call it as polymorphic when multiple areas in the ventricle are becoming the reason for generation of the rhythm. So then the QRS complexes will look different. They don't look same. Then we will call it as polymorphic. Okay. And then we have this ventricular fibrillation. Ventricular fibrillation will almost look like the polymorphic. The only difference is the amplitude of the ventricular fibrillation. Amplitude will be much smaller. So it looks same like the polymorphic, but small amplitude. So whenever you see an ECG with very small amplitude, wide QRSs, but not looking same in terms of morphology, then it is ventricular fibrillation. Okay. So with this background, right, let us get back to this ECG. Now looking at this ECG, right, what is our first step whenever we have a ECG of arrhythmia? To decide whether it is wide complex or narrow complex, right? So when you look at these QRS complexes, right, are they wide or narrow? This is one QRS complex, right? It is clearly wide. It is almost taking 6 small squares, right? Anything more than 3 small square is wide complex tachycardia. So first step is done. We are having wide complex tachycardia. So once we have wide complex tachycardia, so please don't get confused, right? We read from here to here as a one QRS complex. That is our one QRS complex. Yes, it is wide complex tachycardia. So once we have wide complex tachycardia, we have monomorphic VT, polymorphic VT, and ventricular fibrillation as our outcomes, right? Ventricular fibrillation is identified by very narrow or the very small amplitude. Do you think this amplitude is small? It is almost taking 2 large boxes, right? 2 or sometimes more than 2 large boxes. So it is not a small amplitude waveforms. Usually small amplitude, when I say, it takes less than 1 large box. So if I get the same image but taking less than 1 large box, you can think of ventricular fibrillation. So this is not ventricular fibrillation. that is ruled out. So what are we left with? Monomorphic VT versus polymorphic VT. I think all of us can agree that they don't look same. They are different, right? This waveform is so different from this, it is so different from this. So then it is a most likely polymorphic VT. Okay. Then when you look closely, right, can I make it look like a waveform? Can I make it look like a waveform? Does it look like a waveform, right? The sound waves or something, those phonocardiograms you get, it kind of looks like that, right? Yes. Point number one, it is a polymorphic VT, and in fact it is a subtype of a polymorphic VT called as Torsades de Pointes. So in this ECG, first thing we understood that this is a wide complex tachycardia. This is a polymorphic VT, and more precisely it is a subtype of polymorphic VT called as TDP or Torsades de Pointes. So one of the MCQs that they usually ask is, what is the drug of choice for Torsades de Pointes? What is the drug of choice for Torsades de Pointes, right? The drug of choice for Torsades de Pointes is IV magnesium sulfate. Now going back to this question, what will be your answer? You may be getting trapped here. Magnesium sulfate is not the answer. See, now I brought in a bit of tricky ECG image, but in the exam they will give you very classical image which looks like this. Very classical Torsades de Pointes image they will give, and that is a trap. Why that is a trap? Please look into the question, right? What does it say? Okay, I think the options are a bit jumbled here. I will tell you what the best step in the management. We have option A, that is IV magnesium sulfate. Okay. Option B, defibrillation. Option C, cardioversion. And option D, CPR. Okay, so how many of you want to change your choices? Next best step. They're not picking all the management that we will do. Yes, I would like to give the magnesium sulfate. I would like to give the shock. But because here the patient is unresponsive and pulse is not felt, what is the next best step? To start the CPR, right? Once we have done the CPR, as soon as the defibrillator is available, we have to go for the defibrillation. So first is CPR, then defibrillation. Okay. And then if time allows you and you have the access to magnesium sulfate, you can consider using that. But if I change the scenario, same question, means same ECG image, but instead of mentioning patient is unresponsive, I will say patient is conscious and his BP is 110/70. Then how do you deal with it? All you need to do is just give the magnesium sulfate. So the rule of any management of tachyarrhythmias is, if the patient is hemodynamically stable, pharmacotherapy. If the patient is hemodynamically unstable, shock. If patient is unresponsive and pulse is not felt, CPR first and then shock as soon as the defibrillator is available. Okay, cool, good. Okay, so just a quick revision of some important management points, right? So first line management for PSVT. First line management for stable PSVT. What should be our answer? Then the second point is drug of choice for PSVT. Drug of choice for atrial fibrillation. Drug of choice for ventricular tachycardia. The first line management for a stable PSVT is going to be vagal maneuvers, right? Vagal maneuvers. Now what do you mean by vagal maneuvers? You do those physical measures or maneuvers which activate the vagus nerve. It can help you to convert the PSVT to sinus rhythm. So that includes Valsalva or modified Valsalva and carotid massage. So that will be our first step. If that fails, then we go for the drug. The drug is going to be adenosine. Can anybody tell me the contraindication for adenosine? That is also an MCQ point. Drug of choice for atrial fibrillation is going to be amiodarone, and the drug of choice for ventricular tachycardia also today it is going to be amiodarone. Ganesh, yes, we right now use amiodarone as the standard antiarrhythmic drug in clinical practice. What is the contraindication for adenosine? There was one NEET PG question where they had given the setup of the PSVT, adenosine administered. After that, patient became short of breath, and then they had asked what could be the pre-existing condition that this patient may be suffering from. Right? So please remember, adenosine is contraindicated in patients with bronchial asthma. In COPD also, it is kind of relatively contraindicated in patients with asthma because adenosine causes bronchoconstriction. Right? In such cases, if you are dealing with a case of bronchial asthma where PSVT happens, in that case the alternative drug of choice is the calcium channel blockers like verapamil or diltiazem. Okay, good. Okay, so the next topic we are taking is the hypertension. Okay, this is again a standard template that they have been asking in the recent times, so we will just quickly look into it. So in this question, we have a 42-year-old who is diagnosed with hypertension and started on a combination of amlodipine and telmisartan, with which patient failed to achieve the BP target despite the use of full dose of these medications. Then physician started on chlorthalidone. With this also we have, let us say that we have failed to achieve the BP control. Then which of the following medication should be started next? Which of the following medication should be started next? SGLT2 inhibitors, mineralocorticoid receptor blockers, beta blockers, or furosemide? Okay, instead of framing this question this way, right, if I ask you what is the diagnosis here, what diagnosis you would count? Okay, so few points about hypertension, right? So when it comes to hypertension, the first kind of question they will ask you is what is the preferred method for recording the BP, right? Because we know that when we record the BP in the hospital, there is something called as 𝐌𝐞𝐝 hypertension, and that usually gives the higher BP reading, right? So that is why they will ask you what is the preferred method for BP recording. It is not recording in the hospital, not even recording at home, but rather what we call as 24-hour AMBP. AMBP refers to ambulatory BP measurement. That is the preferred method. Okay. Once we record the BP, what is our first line medication, right? What is the first line treatment for a patient with hypertension? The first line treatment is a combination of dihydropyridine calcium channel blockers plus ACE inhibitors or ARBs. That is the recommendation. We start with the low dose. In today's practice, we do not start anyone on, or at least we are not supposed to start anyone on the single drug. Today, polytherapy or polypharmacy is preferred over monotherapy, because when I try to control BP with only one drug, I need to use relatively higher doses and the side effects are common. But instead, if I use smaller doses of two drugs, I get the synergistic result. I will be able to control the BP with minimal side effect of the drugs. If that fails to control, right, then we go for the second line. So what we do in second line is we just switch over this low dose combination to the full dose combination. Full dose combination of dihydropyridine calcium channel blockers and ACE inhibitors is the second line. Means basically I start with small doses of calcium channel blockers, small dose of ACE inhibitors, controlled, good, not controlled, then I go to the full dose of both the drugs. Not controlled, we get into the third line medications. The third line treatment is basically adding a third drug, that is a thiazide-like diuretic. Thiazide-like diuretic, for example chlorthalidone. So once I'm using these three drugs, if my BP is still not controlled, then we call it as resistant hypertension, right? What is the definition of resistant hypertension? Resistant hypertension or refractory hypertension is defined as BP not controlled to its target despite use of three medications at full dose or optimally tolerated dose, out of which one is a diuretic, right? Have we reached that situation? We are using three medications, right? Amlodipine, telmisartan plus chlorthalidone, which is a diuretic. So we are using three medications at full dose or optimally tolerated dose. Out of that, one is a diuretic, still not BP controlled. Then we call it as resistant hypertension. So in this case, the diagnosis will be resistant hypertension. And whenever we have the resistant hypertension, what is the drug of choice? The drug of choice for resistant hypertension is spironolactone, right? How spironolactone works? Spironolactone works by blocking the aldosterone receptor. And what is aldosterone? It is a mineralocorticoid. So blocking the mineralocorticoid receptors is our treatment to go for after we have encountered a case of resistant hypertension. So that is why the answer here will be option B. So I think we have learned few MCQ points. What is the preferred method of BP recording? That is 24-hour ambulatory BP recording. First line treatment is a combination of dihydropyridine calcium channel blockers and the ACE inhibitors or ARBs. Second line is the full dose of the same. Third is adding the thiazide-like diuretic, right? And the fourth line, once we have the resistant hypertension, we add spironolactone. One last question, what is the recommended target for BP? When you say control, what do you mean? Right? When you say control, what do you mean? What is our target BP? How much you want to control? Target BP is to control your systolic to less than 130 and diastolic to less than 80. Less than 130 by 80 is our target. So if the starting BP was 200 and I start some medication and I get to 140/90, it's still not controlled. I still need to go ahead with the next step, right? If I started with the low dose, the dihydropyridine calcium channel blocker and ACE inhibitor, BP has come down from 200 to 140/90. It is still not controlled. I have to go to full dose now. If with the full dose it comes down to less than 130/80, that is where I would declare that the BP is controlled. Good, 𝐒𝐿, absolutely right, absolutely right. Okay, now we have a next topic, which is movement disorders. Recent times in the FMGE as well as NEETPG, they have started including GIF images. So in the last FMGE, they had a GIF image of a flapping tremor and they had asked where it is seen. And we have also seen some GIF images in the previous NEETPGs, especially a couple of years back, where a dancing carotid GIF image was there, a raised JVP GIF image was there, a frog sign GIF image were there. So movement disorders are one topic from which easily they can create a GIF video and put as a question. So we will understand few points about it. So here is a movement disorder question. A 42-year-old presented with new onset involuntary movements affecting one side of the body. Movements are violent and flinging, primarily affecting the proximal muscles. Lesion of which of the following can be seen in this patient? So this patient has developed involuntary movements. Okay, they are affecting only one side of the body. The description of the movements hold the key towards the diagnosis. The movements are violent and flinging. Vikas, absolutely right. Okay, and they are also telling you whether they are affecting the proximal muscles or distal muscles. So when we talk about movement disorders, please remember movement disorders are classified into two groups. In one group, there are involuntary increased movements, right? You have more movements than required and mostly they are involuntary. Second, you have decreased movements. So we classify the movement disorders as hyperkinetic and hypokinetic. Hypokinetic is where the movements are decreased. So under this we have Parkinson's disease and related disorders like the progressive supranuclear palsy, multisystem atrophy, right? All those conditions. So hypokinetic movement disorders, example is Parkinson's disease and Parkinson plus syndromes. When we say hyperkinetic, this is where we need to develop some approach where movements are increased. Hyperkinetic movement disorders are further divided into rhythmic and non-rhythmic. So when we say rhythmic, that means same movement keeps repeating in pattern. Same movement keeps repeating again and again. There are no complex or multiple movements involved. Only one kind of movement keeps repeating again and again, like a rhythm. Right? Such movements are called as rhythmic. There are two types. One of them is dystonia, where one group of muscles are constantly, continuously in a contracted state. Example is torticollis. And the other one is tremors. And non-rhythmic, where it is not the same movement which is repeating, but involuntarily multiple complex movements are happening. Okay, so those include chorea, athetosis, and balismus. When they affect only one side, we use the term hemi, right? If the chorea is affecting only one side, we call it as hemichorea, hemiathetosis, or hemibalismus. If it is affecting both the sides, we simply address it as chorea, athetosis, or balismus. Okay. What are important for the exam? It is the types of tremors and these three movement abnormalities. Okay. Tremors, how do we classify? The tremors are classified as rest tremors, postural tremors, and action tremors. Rest, postural, and action tremors. Rest tremor, as we all know, the classical example is the Parkinson's disease. Okay, what do we call the Parkinson tremor as? Yes, Parkinson's is a classical example for both a hyperkinetic plus hypokinetic movement disorder. So Parkinson's disease, it has three cardinal symptoms, right? What are those cardinal symptoms? One is bradykinesia, second is rigidity, and third is tremors. These three are called as the cardinal symptoms of Parkinson's disease. So bradykinesia is a hypokinetic movement disorder, tremor is a hyperkinetic movement disorder. In addition to that, it also has rigidity. Right, we call it as pill rolling tremors. Why are they called as pill rolling tremors? Because these tremors appear like the patient is holding a pill in between their thumb and the index finger, and they're trying to roll it. So when you see Parkinson's disease patient, this is what they're doing. Pill rolling tremor. Okay. The postural tremors are those tremors which become evident only when the limb is held in a particular posture. They're not there at rest, they're not there on the movement. Only when your limb is held in a particular posture, it becomes evident. A classical example is a flapping tremor or asterixis, where when you ask the patient to outstretch their hands and keep the wrist in extension, they fail to hold it, right? It drops and then again it gets back. It looks like flapping, so it is called as flapping tremor. Another example is the wing beating tremor that you see in patients with Wilson disease. When you ask them to bring their hands close to their eye level and try to approximate, they start developing the movements at the shoulder joint. It looks like the beating of the wings of a bird. We call it as wing beating tremor. Okay. Then when you have a patient with alcohol withdrawal, ask them to stretch their hands like this, they start shaking. So alcohol withdrawal tremor. And then there is one more thing called as essential tremor, which is an inherited tremor. There in many people, including me, we call them as essential tremor. So these are 4 examples for the postural tremor. Can anybody tell me where we get these flapping tremors? Yes, we get the flapping tremors in patients with encephalopathies. It could be metabolic encephalopathy, hepatic encephalopathy, encephalopathy because of carbon dioxide retention, the type 2 respiratory failure that we were talking about, or encephalopathy because of hyponatremia. In all these conditions, including hyperuremia, we can have flapping tremors. Okay, then we have wing beating tremor, which is seen in patients with Wilson's disease. Then we have essential tremor and alcohol withdrawal tremor. Okay. The action tremor is the tremor where we do an intentional action, only then the tremor comes. At rest, it is not there. When you hold the limb against gravity, it is not there. Only when you do some intentional action, we see that. So that is why it is also called as intention tremor. That is seen when you have a cerebellar dysfunction or you have a disorder of the cerebellum. See, after taking some 4 or 5 pegs, if your friend becomes tight and he is not able to reach out to the alcohol glass, it is because he has developed this action tremor. The moment he tries to reach out to the glass, the tremor kicks in, right? तो वो glass कभी पकड़ नहीं पाएगा, हाथ कभी इस type side जाएगा, कभी उस side जाएगा, because the tremor kicks in, right? Alcohol is the most common reason for acute cerebellar dysfunction. So whenever cerebellum gives way, you can have this action tremor or intention tremor. Now coming to these non-rhythmic movement disorders that we were talking about, chorea, athetosis and balismus. These there are complex movements. So it is not only one movement which is repeating, right? In flapping tremor, this, right? In Parkinson's, this. Essential tremor, alcohol withdrawal, only one movement repeating. Wing beating, only one. Actually, the movement is happening at the shoulder joint. But when there are multiple complex movements involved, we will call them as non-rhythmic. There are three types: chorea, athetosis, and balismus. To identify these, mainly you have to look at two descriptions. The question usually describes whether the abnormal movements are at the distal parts of the limbs or the proximal parts, right? So please remember, athetosis and chorea affect the distal parts, and balismus primarily affects the proximal muscles. The term proximal refers to the muscles closer to the shoulder joint and muscles closer to the hip joint. So when you have balismus, the movements are happening at the shoulder joint. When you say athetosis and chorea, the movements are happening at the distal groups, right? The muscles away from the shoulder joint, mainly the hand, right? So when patient is doing these abnormal movements at the wrist or elbow, that can be chorea or athetosis. When the movements are happening at the shoulder joint, it is most likely going to be balismus. Okay. Apart from that, there will be additional clues given in the way the examiner describes the abnormalities. So whenever he describes that distal muscles are showing the abnormal movement and it is described as dance-like, then it is called as chorea. In fact, the term chorea comes from the parent word, the choreography. It looks like the movements are choreographed. Okay. And whenever in the question description they mention the word like snake-like or writhing movements, slow writhing movements, then it is talking about athetosis. So hand movements, very slowly they are moving like this constantly. Patient is doing some slow movements. That is athetosis. The word balismus originates from ballet. So in ballet, right, when the couple are dancing in ballet, usually the male protagonist lifts the woman and moves her in the air and then again lands her back on the ground. So those movements are flinging movements. So whenever the description of the question says there are violent or flinging movements, it is talking about balismus. Violent or flinging movements, it is talking about balismus. In fact, I tell my PG students that if you have a patient with the balismus, never go near, because the movements are happening at the shoulder joint. So they have a wide range where the movements will happen. You never know in which direction the hand is going to come next, right? आपका जबड़े पे भी एक मार land हो सकता है. So staying some distance from a patient with balismus is very important, because these movements are not like some Bharatanatyam or Kathakali. It's not like going to be like chorea or athetosis. These are very violent and flinging movements. At times, patients have dislocated their own shoulder joints during balismus. Right? So if you get the word violent or flinging movements, it means patient has got balismus. So in this case, clearly they have mentioned that there are violent and flinging movements. Right? And they've also mentioned that it is affecting the proximal muscles, means muscles around the shoulder girdle. And it is one-sided. So that means what is our diagnosis here? The diagnosis becomes balismus, and because it is one-sided, we will call it as hemibalismus. So this question is talking about hemibalismus. Now the last bit we need is the site of lesion. See, they can ask site of lesions for most of these. Parkinson disease, we know, right? What is the site of lesion? Substantia nigra, right? What is the site of lesion for the wing beating tremor in patients with the Wilson's disease? It is the basal ganglia where the copper is getting deposited. Essential tremor, unknown. Alcohol withdrawal, partially cerebellum. Action tremor, cerebellum. Okay. So the site of lesion for chorea is in the caudate nucleus of the extrapyramidal system. The caudate nucleus. The lesion of the caudate nucleus produces chorea. Easy to remember because it is C for C. Chorea for caudate nucleus. Athetosis is generally due to lesion in the putamen. Again, putamen is part of our extrapyramidal system. So when you have a lesion in the putamen, you can develop the athetosis. And balismus is usually due to lesion in subthalamic nucleus or STN. Subthalamic nucleus lesion produces the balismus. Caudate nucleus chorea is easy to remember, C for C. And one way to remember the balismus, the lesion being subthalamic nucleus, is think of a violent batsman. For me, the batsman who is very violent with the movement of bats, right? You know, the helicopter shot. That's a very violent movement of your shoulder joint to get that helicopter shot. Who does that? Dhoni. Dhoni is popularly addressed as Thala, right? So that way you can remember that it is the subthalamic nucleus. Thalamic nucleus is where if there is a damage, we get the balismus or hemibalismus. Yes, dance like, that is chorea. So this case has hemibalismus. The lesion has to be in the subthalamic nucleus. So please remember Thala, Dhoni, helicopter shot, violent shot, violent flinging movements, hemibalismus. Okay, so that's about the movement disorders. Next topic is our respiratory failure. If they don't ask a question on the ABG interpretation, then they will generally ask a question on the respiratory failure. Okay, most of the Thala for a reason. Okay, most of the recent questions were focused on a peculiar type of respiratory failure. So here is a data. A 42-year-old is hospitalized with septic shock. Septic shock means he has infection which has led to sepsis. His ABG is given below. Which of the following type of respiratory failure is seen here? pH is 7.1. I think we know that patient has got some acidosis. Okay, PaO2 is 58, PaCO2 is 55. So forget about the ABG abnormality here. Concentrate on the respiratory failure. So which type of respiratory failure this patient is suffering from? And meanwhile, when you answer the question, right, I have one more question. What is the diagnostic criteria for sepsis and septic shock? Okay, so Lakshita Parmar says this is type 2. Okay, how many of you agree that this is type 2 respiratory failure? Writhing refers to, you know, when we get up and do this, like angdaiya lete hain, that is writhing. So if the movements are like that, it's called as writhing movements. So that's why it's also described as snake-like, right? Snake kaise move karta hai. Okay, so first thing is, let us also talk a little bit about sepsis because that's also an important topic. I'll come back to the respiratory failure in 2 minutes. Okay, what is sepsis? What is sepsis? What do you mean by sepsis? I know what answer you are going to say, right? So you will say infection into the blood. Wrong. Infection or bacteria getting into the blood, we will call it as bacteremia or septicemia. Fungi getting into the blood, we will call it as fungemia. Viruses getting into the blood, we will call it as viremia, right? So septicemia is not sepsis. Okay, so how many of you know this thing called as 𝐒𝐄 𝐶? Right, what is this SOFA and 𝐶? Right, there is something called a SOFA and a 𝐶. Tell me the full form of this. SOFA stands for sequential organ failure assessment. Sequential organ failure assessment. A concise version of the SOFA is what is called as quick SOFA or 𝐶. Okay, what is it used for? SOFA is used for diagnosis of sepsis and 𝐶 is used for early recognition or screening of sepsis. So then what is sepsis? Why are we using this sequential organ failure? So please remember, sepsis refers to infection leading to organ failure. Infection leading to organ failure. So an infection leading to organ failure is sepsis, and that is why we are using the organ failure assessment for diagnosis of sepsis, right? The diagnosis of sepsis follows this criteria. Right? Infection plus acute rise in SOFA score. SOFA is a scoring system. Score by more than or equal to 2. Infection plus acute rise in the SOFA score means your organs. In the SOFA score, we assess your kidneys, your mental status, mental functions, the cardiovascular status, hematological parameters, multiple organ functions we assess. And if the organs start losing their function, we give them score. So when your score jumps by 2 points in presence of infection, we call it as sepsis. That is the diagnostic criteria. Infection plus acute rise in SOFA score. Conceptually, when infection leads to failure of organs, we call it as sepsis. So if I have infection, my organs are fine, I don't have sepsis. Okay. Now coming to this respiratory failure. The backdrop is set, patient has got septic shock. So when sepsis leads to, right, sepsis with hypotension or tissue hypoperfusion, we call it a septic shock, or tissue hypoperfusion, then we call it as septic shock. Okay, so now coming to the respiratory failures. So we have different types of respiratory failure. Basic function of the respiratory system is take the oxygen from the air and put it into your blood, take the carbon dioxide from your blood and put it into the environment, right? Oxygenate the blood, clear the carbon dioxide. That is a function. When any of these functions are disturbed, we call it as respiratory failure. Either we are not able to oxygenate the blood or we are not able to clear the carbon dioxide from the blood. Then we call it as respiratory failure. So how do we approach respiratory failure? Whenever you have impaired oxygenation or impaired carbon dioxide, when you look at the ABG, right, in the ABG, first thing you should see is the PaCO2. Okay, if the PaCO2 is increased, then we will call it as type 2 respiratory failure, irrespective of type 2 respiratory failure, irrespective of what is happening with oxygen. Oxygen may be normal, may be increased, decreased, doesn't matter. As long as carbon dioxide is increased, it is type 2 respiratory failure. That is the first important message that we need to understand today. And if it is not increased, when I say not increased, it means it may be normal or decreased, doesn't matter. As long as it is not increased, it is not type 2 respiratory failure. If it is not increased, then we will look at PaO2, partial pressure of oxygen. If the partial pressure of oxygen is decreased, then we will call it as type 1 respiratory failure. And what if the partial pressure of oxygen is not decreased, means normal? Then what kind of respiratory failure it is? Your drug of choice, yes, conceptually that's right. Losing multiple organs because the infection is disturbing the organ functions. So if I have a patient where ABG, PaCO2 is not increased, PaO2 is not decreased, then what kind of respiratory failure it is? There is no respiratory failure. This is normal ABG, right? Normal, no respiratory failure. See, there are only two functions of the respiratory system that we are talking about. One, oxygenation, second, carbon dioxide clearance. So when carbon dioxide is not increased, carbon dioxide clearance is not affected, right? When oxygen is not decreased, that means oxygenation is also not affected. So that is normalcy, right? So this is the approach we should follow. Okay, so now get back to this question and follow this approach. First thing what we should see, partial pressure of the carbon dioxide. If the partial pressure of the carbon dioxide is increased, it is type 2. If that is not increased, then we look at the oxygen. If oxygen is decreased, it is type 1. If both are not affected, it is normal. So in this case, what is happening to the partial pressure of carbon dioxide? It is increased, right? Normal partial pressure of carbon dioxide is 35 to 45, right? Normal partial pressure of oxygen is 80 to 100. If you go by conventional method, then oxygen is decreased, carbon dioxide is increased, right? We are not looking at that. First thing we see is the carbon dioxide, and the carbon dioxide is increased. As long as carbon dioxide is increased, we generally count it as type 2 respiratory failure. Clear? So type 1, we call it as hypoxemic. In type 1, the only problem is hypoxia. Type 2, whether you have hypoxia or not does not matter. You have hypercarbia or hypercapnia. But apart from type 1 and type 2, we have two more special types of respiratory failure. Okay, so we have a type 3 respiratory failure. Type 3 respiratory failure refers to any type of respiratory failure. Any type of respiratory failure. It may be type 1 or type 2 occurring in peri or post-operative patients. Post-operative patients, it is generally due to lung atelectasis. Lung atelectasis means when surgeries are done, especially abdominal surgeries, especially laparoscopic surgeries, lower part of the lung gets collapsed. Why does it get collapsed? Because for the abdominal surgeries, especially laparoscopic surgeries, we insufflate carbon dioxide into the abdomen, right? We expand the abdomen, but we push the diaphragm up. So when the diaphragm gets pushed up, the lower portion of the lung gets collapsed, right? Once it gets collapsed, that much part of the lung is not participating in the gas exchange. So because of that, your oxygen level starts dropping down. So most likely you will end up getting type 1 respiratory failure. But because it is happening in a specific setting, that is peri or post-operative period, which is due to lung atelectasis, we call it as type 3 respiratory failure. There's a reason why we have called it as a separate category. Because for these patients, giving oxygen does not solve their problem because the collapsed lung need to expand. So for that, these patients would require chest physiotherapy and incentive spirometry. When they blow air into the spirometer, the lungs will expand. That's why we have created a separate category, right? So treatment for this is chest physiotherapy, not oxygen is not important here. Chest physiotherapy and incentive spirometry. Just make the collapsed lung open. It is not a pathologic lung, it's just collapsed. There's no pneumonia or anything. So once it opens, it will participate in the gas exchange and your respiratory failure is gone. Then we have a type 4 respiratory failure also. Type 4 respiratory failure refers to any type of respiratory failure happening in patients with, so when I say any type, it may be type 1 or type 2, occurring in patients with shock. Again, a very, very important point. When the patient is in shock and develops the respiratory failure, we call it as category or type 4. ABG may show it as type 1 or type 2, but the backdrop is important. The backdrop is a patient with shock, then we call it as type 4. The reason for that is, think of a patient who is in shock, means his heart is not able to perfuse your tissues, right? On the other hand, you also have a respiratory failure, so you are not able to either clear carbon dioxide or get oxygen into your blood. Now what your respiratory system will do, it will activate all your accessory muscles of respiration. So you are doing a very laborious breathing, right? All your accessory muscles of respiration are contracting. Now what will happen to the need for blood supply by those extra muscles which are now active? The need for blood supply by these accessory muscles of respiration, obviously they will require more blood supply, but you are in a state of shock, you're not able to give that sufficient blood supply. So will you be able to improve your respiratory parameter? Probably no. But there is one major problem that this can bring in. Most part of the cardiac output is taken up by the respiratory muscles. So when you have shock, right? When you have shock plus respiratory failure means that cardiac output is consumed by respiratory muscles. Most of your cardiac output is consumed by respiratory muscles and less amount of blood is going to your vital organs, right? So there is vital organ hypoperfusion. Your vital organs are not going to get sufficient blood supply. So that leads to organ failure. If your kidney is not getting sufficient blood supply, it gets into acute kidney injury, right? If your brain is not getting sufficient blood supply, it goes into hypoxic ischemic encephalopathy. If your liver is not getting sufficient blood supply, it goes into ischemic hepatitis. So your organs start failing. Now in such case, right, if I just give the oxygen, the problem is not solved. Whatever this cardiac output that is being consumed by respiratory muscle, it needs to be diverted back to the vital organs. Only then the patient's problem is solved. So how can I solve that problem? How can I solve this problem? How can I divert the cardiac output back to the deserving vital organs? By making these respiratory muscles stop overworking, right? The respiratory muscles are overworking. If I have to stop them, then all the cardiac output will be diverted to vital organs. How can I make the respiratory muscles stop overworking? By taking the responsibility of doing the respiration for the patient instead of leaving it to the muscles. How can I take the responsibility from the muscles? By putting the patient on the mechanical ventilator. So every time you have a patient with shock and respiratory failure, even if it is a mild respiratory failure, that requires ventilatory support. Otherwise, we will end up losing the vital internal organs. So for the type 4 respiratory failure, the treatment is directly mechanical ventilation. Once I put the patient on ventilator is doing all the work. Your respiratory muscles don't need to do the work. I can also give a neuromuscular blocking agent like 𝐒𝐿 and paralyze the muscles. They don't require much blood supply. All that blood supply that heart can generate now can go to the kidney, lungs and liver. So because here, instead of wasting your time to first give oxygen, then BiPAP or CPAP, then go to ventilator, the moment I know that this is a case of shock, I should intubate the patient and put on the ventilator. That is why we created a type 4. Okay, so now looking at this question, what do you think is the answer here? Answer is pretty straightforward, right? They have mentioned that patient is in septic shock. So the moment I see that there is shock, I don't need to waste my time on the type of respiratory failure on the ABG. Directly I will go ahead and choose the answer as option D. If I told that this is a post-operative patient and he has developed some mild respiratory discomfort and ABG is done, which type of respiratory failure? Whatever ABG shows, as long as there is some abnormalities on the ABG, it is going to be type 3. Only when that backdrop is not there, not a case of shock, not a peri or post-operative patient, only then I have to spend time on interpreting the ABG. Approach is simple. Start with the PaO2, right? PaCO2. PaCO2 increased, type 2. PaCO2 not increased, then look at the PaO2. PaO2 decreased, type 1. PaO2 also not decreased, PaCO2 also not increased, then it is normal ABG. Clear? Okay. So the next topic, repeatedly tested concept, that is pleural fluid analysis. Basically they test you with the lights criteria, right? So here we have a 42-year-old who presented with cough and shortness of breath. On examination he has dull percussion note on the right hemithorax and chest x-ray revealed right pleural effusion. So they have clearly told that there is pleural effusion on imaging. Question is, which of the following findings on pleural effusion indicate exudative effusion, right? So to differentiate between exudative and transudative, we follow a criteria which is called as lights criteria. We mainly look at the 2-3 important parameters. The first one is the pleural fluid and serum protein ratio. If the ratio is more than 0.5, or in other words, whatever I get the serum protein, if the pleural protein is more than 50% of that, then it is exudative. Or second thing, I can look at the LDH, the ratio of LDH in the pleural fluid and the serum. If the ratio is more than 0.6, it is exudative. Or if the pleural fluid LDH is more than 2/3 of the upper limit of normal for serum, then also it will be counted as the exudative, right? So here is a summary of that lights criteria. The first one is looking at the protein. We are looking at the ratio of pleural fluid protein by serum protein. If the ratio is more than 0.5, it is exudative. Second, we are looking at LDH. We are looking at the ratio of pleural fluid LDH and serum LDH. If it is more than 0.6, it is exudative. Within that, we have one more parameter, which is pleural fluid LDH more than 2/3 the upper limit of normal for the serum LDH. That will also be counted as exudative. So option A can't be counted as exudative. Without a ratio, we can't come to the conclusion exudative or transudative. Dull note on percussion, it need not always even mean that there is pleural effusion. We can get the dull note on percussion when there is an underlying tumor there. We can get the dull note on percussion when we have the consolidation. If we have a consolidation or pneumonia, we will have the woody dullness, right? If we have the effusion, we will have the stony dullness. Option D, pleural fluid protein by serum protein ratio less than 0.5 actually indicates there is transudative effusion, right? First one is inconclusive because it is not a ratio. So we are only left with option B, pleural fluid LDH more than 2/3 of the upper limit of normal for the serum LDH. That indicates a exudative pleural effusion. Those who are not familiar, just by heart this table. This will most likely come and might give us 1 mark in the upcoming exam. Okay. So the last topic is on the gold guidelines for the COPD. And gold guidelines are like overhauled or completely changed in 2023. So that makes it a bit difficult for those who are following the older versions of the apps, not only PW, any app. If you're not updated, you're not subscribed to the newer version, you may be oblivious to the changes. Okay. So let us see if you can interpret this. We have a 58-year-old smoker diagnosed with COPD. He was hospitalized once in last 1 year for COPD related complaints. His shortness of breath puts him at grade 3 MMRC. So in COPD, we assess the severity of dyspnea using 2 tools. One of them is called as COPD assessment tool or CAT. The other one is called as Modified Medical Research Council grade or MMRC. Identified the correct match from the below regarding gold category and initial management. So let me see how many of you can give me the answer. So whenever we make a diagnosis of COPD, according to gold guidelines, first thing is we have to fix them into a category. So we have three categories, category A, category B and category E. Once we fix them into a category, then we decide what is our next step, like what will be the initial prescription for the patient. Okay, so how we decide that category? Okay, so here's a small table which kind of summarizes the approach to decision of the category. Okay, so in this table they have plotted the MMRC or the CAT score of the severity of dyspnea and the history of exacerbations. So based on this information from the question, we can decide whether it is category E, A or B. But I'll try to simplify it for you using a slightly different approach. So whenever we have a patient with COPD, the first thing I want you to see from the question is the history of exacerbations. Once the COPD is diagnosed, right? History of exacerbations becomes the most important point. Exacerbations. And when I say history of exacerbations, what question I want you to look into the question is whether patient had more than or equal to 2 moderate exacerbations or more than or equal to 1 severe exacerbation. When I say severe, it refers to requiring admission or hospitalization. This is the information I want you to gather from the question. This is our step number 1 to understand the category. Okay, what we need to know in last 1 year, right? History of exacerbations in preceding 1 year. So in last 1 year, whether patient had 2 or more than 2 moderate exacerbation. Now what is this moderate exacerbation? Moderate exacerbation is the one that required patient to visit a doctor. Mild exacerbation is the one which patient did not require to visit a doctor. He managed himself. Severe exacerbation is the one where patient had to get admitted in the hospital. Right? So now go back to this question and look at it. Whether this patient, like this is a question I am posing to you, right? Whether patient had 2 or more than 2 moderate exacerbations or 1 or more than 1 severe exacerbation in last 1 year, right? So for this question, looking at the data given in this question, would you answer yes or no? Whether this patient had more than or equal to 2 moderate or more than or equal to 1 exacerbation or both of them were not there. See, clearly in this question they have mentioned that patient was hospitalized once, right? That means in last 1 year he had 1 severe exacerbation, right? He had 1 severe exacerbation. So when you decipher this question, if the answer for this is yes, then the patient goes into category E or group E, And if the answer is no, means patient did not have more than 2 moderate exacerbation, neither he had 1 or more than 1 severe exacerbations. So for both these questions, if our answer is no, then he has to go into either category A or B. Now how do I differentiate between A and B? That is where the MMRC grade comes into picture. If the MMRC grade of dyspnea is 0 to 1, then the patient will go into category A, and if it is more than or equal to 2, then the patient will go into category B. Okay, so once we have categorized, we have to decide how do we manage, right? So category A patient is treated with any bronchodilator. Means you can either give LAMA or you can give LABA. But for category B patient and category E patient, we treat with a combination of long-acting antimuscarinic agent plus long-acting beta agonist. Same applies to category B, long-acting beta agonist plus long-acting antimuscarinic agent. So only thing you need to remember is look at the COPD description, see whether patient had 2 or more than 2 hospital visits in last 1 year or any 1 hospitalization. If between these two anything has happened, then it is category E. Put him in category E and start on LAMA plus LABA. If these things have not happened in 1 year, right, then look at the MMRC. If the MMRC grade is 0 to 1, put him in category A and start either of them, LAMA or LABA. And if the MMRC grade is 2 or more than 2, then put him on category B and then again start him on LAMA plus LABA combination. So in this case, now what should be your answer? I have given you the algorithm to approach it, right? Alternatively, you can also get that data whether patient had moderate exacerbation, hospitalization, MMRC, and then you can plot here and you can come out with the conclusion. But this is a more simplistic approach. Just find out the answer for this question, yes or no. Yes, category E, no. Then look at the MMRC grade, 0 to 1, category A, more than or equal to 2, category B. So which category it is? Right, patient was hospitalized once in last 1 year, right? He was admitted once. So then what category he becomes? He becomes category E, right? He becomes category E. And what is the treatment for category E? Category E needs to be treated with LAMA plus LABA. LAMA plus LABA. So there is no appropriate answer for, like there is no appropriate choice in the answers listed here. They should have been either category E, LAMA plus LABA. Then option C becomes the correct answer, right? And in this question only I can make the modification saying that he has no hospitalization at all in the last 1 year. No hospitalization. In that case, what will be this patient's category? Same question, 58-year-old, COPD, no admission, no exacerbation at all. In that case, what category he should be? When there are no significant exacerbation, category E is out. Either he has to be A or B. And between A and B, how do we differentiate? By looking at the MMRC grade. If it is category if it is category E, MMRC grade doesn't come into picture. If admission or 2 plus moderate exacerbation, directly category E. Once I have ruled out category E, I have to look at the MMRC grade. 0 to 1, category A, right? 3, it will become category B, right? So in that case, what will be your answer? Right, in that case, it will become category B. So there are two options here for category B, right? Option B and option D. What will you choose? What will you choose? So for only category A, we have a choice of choosing either LAMA or LABA, right? For B and E, it is always a combination of LAMA plus LABA. So then option D becomes the right answer. Good, very good. So the correct answer will be option D. So please remember this approach. I am anticipating some questions on this time. Okay. Now, having done with the 10 important topics, we will quickly scan through 10 important images. Okay. I'll start from the bottoms up. Okay. So look at the image number 10. What is it showing? What is it showing? 2-3 points I will tell you. First, what is it showing? You can see some hyperpigmentation, hyperkeratinized area around the neck, right? What do we call this as? Yes, this is acanthosis nigricans. What does that indicate? This is acanthosis nigricans. What does that indicate? Yes, it indicates insulin resistance and which type of diabetes it is seen. So not only insulin resistance, we have to know which type of diabetes it says. Yes, metabolic syndrome is one, and if it is diabetes, which type of diabetes? If I get a patient with diabetes and I have seen acanthosis nigricans, should I consider it as type 1 diabetes, or should I consider it as type 2 or maturity onset diabetes in young, or LADA, right? So it indicates type 2 diabetes mellitus, right? So either you can see it in patients with metabolic syndrome or in type 2 diabetes mellitus. In one of the NEET PG exam, there was a question where they had asked which of the following is not seen in MODY, maturity onset diabetes in young, right? So when it comes to insulin resistance, only type 2 diabetes mellitus should come to your mind. Whether it is type 1, LADA, MODY, there is no role of insulin resistance, so you will not see acanthosis nigricans in type 1, in LADA and in MODY. Okay. Now, image number 9, what comes to your mind? What is the finding here? Again, an endocrine disorder. Endocrine disorder. Which animal comes to your mind when you look at this? Right, so this is what we call as buffalo hump. Buffalo hump. Where is it seen? It is seen in patients with, should I write Cushing's syndrome or Cushing's disease? What is the difference between Cushing's syndrome and Cushing's disease? What is the difference between Cushing's syndrome and Cushing's disease? Please remember, Cushing's syndrome is a broad term. It means excess cortisol. Whatever may be the reason, it may be external administration of steroids, it may be an adrenal carcinoma, right? It may be an ACTH producing adenoma stimulating the adrenal gland to produce cortisol. Whatever is the reason, excess cortisol leading to clinical manifestations, we call it as Cushing's syndrome. Cushing's disease specifically means a ACTH producing pituitary adenoma is the reason for excess cortisol. Then we call it as Cushing's disease, right? So Cushing's disease is a broad term. In simple words like diabetes mellitus. What does that mean? Hyperglycemia, right? Diabetes mellitus due to insulin resistance is type 2. Diabetes mellitus due to antibodies causing beta cell destruction is type 1, right? So Cushing's syndrome is just like diabetes mellitus, a broad term. Cushing's syndrome due to ACTH producing pituitary adenoma is equal to Cushing's disease. Good. Okay, now when you look at this image, what comes to your mind? So what you notice here is that there is prognathism, frontal bossing, right? Coarse, stuffy nose. I'll give you a clue. Sometimes they will give you this image and then in the question they will mention that patient presented with increasing ring size and shoe size, right? So this should be suggestive of acromegaly. Acromegaly. Good. Okay. Now this image, what comes to your mind? There are arrow marks pointing towards the right heart border. Arrow marks pointing towards the right heart border. And when you look closely, you see that right heart border has two lines or two shadows. Yes, this face almost looks like 𝐒𝐿, right? Almost same features. 𝐒𝐿 also has acromegaly. It is not pericardial effusion. See, in the pericardial effusion, you will not have this finding where you can see that two outlines for the right heart border. So this condition is what is called as double density sign or double right heart border. Double, this is not money bag. See, money bag, what happens? It widely spreads out like this. In constrictive pericarditis, you will have a rim of calcified pericardium around the heart. So this finding where you can see double shadows or two lines to the right heart border is called as double density sign or double right heart border. Double density sign, also known as double right heart border. Heart border. So this indicates that you have left atrial enlargement. It indicates left atrial enlargement. Left atrial enlargement. So basically your left atrium is there somewhere here. So when it starts expanding, right, the axis of expansion is primarily in this direction. So first thing that happens is your left heart border becomes straight. That is the early finding. Straightening of left heart border indicates left atrial enlargement. But if you remember your autopsy days, right, your the dissection days in first MBBS, you might have noticed that only small portion of the left atrium is visible anteriorly because it is more curled posteriorly. When it starts expanding, it goes on expanding posteriorly and it comes to lie like this is where you have it. It goes on expanding like this and then eventually comes to lie closer to the right heart border. So now one line is visible because of the left atrium and the other is because of your usual right heart border. So this two borders is what we call as double density sign or double left heart border. It indicates left atrial enlargement. What is the most common cause for such a massive left atrial enlargement? The most common cause is mitral stenosis. Mitral stenosis can also be seen in mitral regurgitation. Okay, so when you see this image, what comes to your mind? Your drug of choice, absolutely right. So straightening of left heart border and double density sign or double right heart border. These are two radiological findings of enlarged left atrium. So when you see this image, the first thing that should come to your mind is hemispatial neglect. Hemispatial neglect. Okay. The damage to which part of the brain leads to hemispatial neglect? Damage to which part of the brain leads to hemispatial neglect? Absolutely right. This should prompt hemispatial neglect. It is seen in damage to non-dominant parietal lobe. Non-dominant parietal lobe. Non-dominant parietal lobe lesions. Non-dominant parietal lobe lesions. Dominant parietal lobe lesion leads to the damage to angular gyrus producing Gerstmann syndrome and the sensory dysfunction. Okay. Now this ECG, when you look at this, what is the striking finding you notice? Let me draw your attention to the striking findings. Look at the QRS amplitudes. QRS amplitudes. What is happening to the QRS amplitude? Alternatively, you have a small amplitude and large amplitude. Small amplitude, large amplitude, right? Look at this. This is large, small, large, small, large, small. So this finding is called as electrical alternance. This is called as electrical alternance. In what condition we see that? Alternating small and large amplitude QRSs. Small and large amplitude QRSs. Where do we see that? In what condition? Yes, it is electrical alternance. Where do we see it? So this is usually seen in patients with cardiac tamponade. Not in constrictive pericarditis. It is usually seen in patients with cardiac tamponade. So what happens in cardiac tamponade is you have a pericardium which is full of fluid, and within that you have the heart, right? And this heart, within that fluid, is moving to and fro. It is jerking inside the pericardium. So you can say pericardial effusion or massive pericardial effusion or cardiac tamponade. So when it comes closer to the chest wall, the QRS amplitude becomes larger because the electrodes are recording it from the surface. When it moves away, the amplitude becomes smaller. So typically seen in massive pericardial effusion or cardiac tamponade. Massive pericardial effusion or cardiac tamponade. Okay, now I think you can pick up, right, what this is indicating, what this X-ray is suggestive of. This is the money bag heart or water bottle heart, right? Money bag heart or water bottle heart. Where do we get that? Money bag or water bottle heart. Right, we get that in massive pericardial effusion. Pericardial effusion. Okay, good. Next, when you see this image, what comes to your mind? What do you notice here? This is the image that National Board of Examination has stolen from the internet, and in several past exams they have used the same image. The students come after the exam and say that, sir, there was some biopsy image or autopsy image, and then when I showed them this internet image, they said, "Huh, sir, exactly same image had come." Right, so here we can see this banana shaped left ventricle, right? We can see asymmetric septal hypertrophy. So we call this condition as HOCM, right? Banana shaped left ventricle, and the diagnosis will be hypertrophic obstructive cardiomyopathy. Good. Yes, it is the most common cause of sudden cardiac death in young individuals and athletes. Okay, what is this image? What is this image? Cause of death, yes, VT and VF. In terms of obstructive symptom treatment, step number 1 is alcoholic ablation. Not feasible, you can do septal myomectomy. So this device is called as 10-gram monofilament, 10-gram monofilament, or it is also known as Semiz-Weinstein filament. Semiz-Weinstein filament. So it is not used for the diagnosis of neuropathy. It is tried on a patient with sensory neuropathies to understand whether the sensation is sufficient enough to protect their feet from trauma, right? So in simple words, this is used for detection of LOPS. LOPS refers to loss of protective sensations. Loss of protective sensations. So if you can feel this, see when this is applied on anybody's feet, right, it can only transfer 10 grams of pressure. More than that cannot be transferred because after that it buckles. So when you press, only 10 gram pressure is exerted. If patient can feel it, that means he has the protective sensation. He will be able to feel the trauma, and any injuries he will be able to report or get treated. If he can't feel it, then he has lost the protective sensation and his feet needs extra care. So this is used for detection of LOPS. Okay. Now if I tell you that a patient with fever and neck stiffness and this examination is being done, what will be our diagnosis, or what the sign is being demonstrated here? Sachin Rajput, it is not for detection of peripheral neuropathy. That is again a common mistake. In fact, in the last exam they had asked the same question. What is it used for? For diagnosis of peripheral neuropathies, either we rely on clinical examination. What clinical examination? When nerves are damaged, sensory neurons are damaged, so there will be loss of sensations. It might have motor neurons. So if the motor neurons are damaged, there will be a flaccidity, right? Decreased tone, decreased deep and reflexes. So that is a clinical judgment of neuropathy. And the laboratory confirmation is with a nerve conduction study. But once I have established that a particular patient has neuropathy, now to understand how severely the neuropathy is affected him, whether he can protect his own feet or not from micro trauma, to decide that we use this 10 gram monofilament, right? So this is nothing but our Kernigh's sign, right? This image is demonstrating the Kernigh's sign for diagnosis of, should I say meningitis or meningeal irritation? Should I say meningitis or meningeal irritation? It is for meningeal irritation. So meningeal irritation need not always be because of meningitis. If I have subarachnoid hemorrhage, this can be positive, right? If I have cancer spreading to the meninges, this can be positive. So this only indicates meningeal irritation. Couple that with acute onset fever and headache and the neck stiffness, then we make the diagnosis. So if they specifically ask you, does it indicate meningitis? Need not always be. It can also be because of any other cause for meningeal irritation. The most common cause after meningitis is subarachnoid hemorrhage. Okay, so after done with 10 images, we have a quick take on some 10 important MCQ points. Okay, so we'll start with them quickly, one by one. What is the most common cause for mitral stenosis? Okay, how many of you are going to answer this? What is the most common cause for mitral stenosis? What is the most common cause for mitral stenosis? The most common cause for mitral stenosis is rheumatic heart disease. Awesome. Okay. In what condition we see locomotor brachialis? Locomotor brachialis. Locomotor brachialis refers to visible brachial artery pulsations. Normally when you see the brachial artery, the pulsations are not visible. We can only feel it. We can only feel it. Right? But if I can see the brachial artery pulsation, we call it as locomotor brachialis. So in which valvular heart diseases we start seeing pulses everywhere? Like carotid starts dancing, right? Forehead capillary pulsations giving right to lighthouse sign. Where do we see pulsations becoming visible everywhere? Yes, that is aortic regurgitation. So locomotor brachialis is also seen in aortic regurgitation. Why that happens? Because in aortic regurgitation, there is increase in systolic pressure, decrease in diastolic pressure. So that makes the pulse very much visible. So everywhere the pulses become visible. If the brachial artery is becoming visible, we call it as locomotor brachialis. Okay. What is the earliest sign of pyramidal tract lesion? Earliest sign of pyramidal tract lesion. I'll give you a clue, right? We ask the patient to outstretch their hands and hold it in supine position like this. Okay, and the affected hand, if one side there is a pyramidal tract lesion and I have weakness, then slowly I will not be able to hold it in supine position. Slowly it will pronate and the hand will drop down. So what do we call that as? What do we call that as? We call it as pronator drift sign. Pronator drift sign. The weaker side, patient is not able to hold in supine, it pronates and drifts away. So we call it as pronator drift sign. The sign is also called as Barry's sign. It is also called as Barry's sign or Barry's sign. Okay. What is the algorithm currently followed for early recognition of stroke by the layman or paramedics who are attending a patient with stroke? Okay, so there is an algorithm called as Be Fast. Be Fast. Be Fast. Yeah, Fast was the earlier version. Now we have Be Fast. So in the Be Fast, B refers to balance and E refers to eye abnormalities. Be Fast. So previously fast, now Be Fast. Okay, so F for facial asymmetry, right? And E for eye abnormalities and B for the imbalance. So eye abnormalities and imbalance were earlier not part of it. Okay. S for speech abnormalities and T refers to time. Okay, next one, most common toxin responsible for dilated cardiomyopathy. Most common toxin responsible for dilated cardiomyopathy is A for arm weakness. Most common toxin, see, dilated cardiomyopathy में क्या होता है? Left ventricle becomes too dilated, right? Normally it should be less than 6 centimeters in diameter. It becomes more than that, then we call it as dilated cardiomyopathy, right? Alcohol, right? Alcohol पीने से दिल बड़ा हो जाता है. That's the easiest way to remember. Alcohol is the most common toxin. Can anybody name me another toxin other than alcohol which can cause dilated cardiomyopathy? Yes, titin mutation is the most common reason for inherited dilated cardiomyopathy or familial dilated cardiomyopathy. Any other toxin? I'll give you a clue. When you take this toxin, right, you can feel that there are insects crawling on the body. Insects crawling on the body. Where do we get that? That's again a usual psychiatric question. Some intoxication and patient feels that insects are crawling on the body. Right, that is cocaine. Cocaine can also cause dilated cardiomyopathy. Good. Okay. Then toxin responsible for Balkan nephropathy. This is one of our previous FMGE question. Toxin responsible for Balkan nephropathy. What is Balkan nephropathy? It is a chronic tubulointerstitial disease. Means tubules and interstitium of the kidney get affected. Chronic tubulointerstitial disease due to chronic exposure to a toxin. The toxin, many of you may be familiar. No, it is not lead. The toxin is called as aristolochic acid. Aristolochic acid. So just remember this point. They have asked it, so we are getting into it. More details are not required for us. Okay. Then one more question. A biological useful for non-type 2 asthma. I think most of us know that asthma patients are divided into type 2 and non-type 2. Most of the monoclonal antibodies that we have are primarily meant for type 2 asthma patient. Only one is suitable for both type 2 and non-type 2. Which one is that? Interleukin 1 inhibition has not much role in the management of asthma. Where do we use interleukin 1 inhibitors? A classical example for interleukin 1 inhibitor is anakinra, right? So we use anakinra in rheumatoid arthritis. We used to use, not any day. Now we have anyway TNF alpha inhibitors. We use it for treatment of familial Mediterranean fever and sometimes for patients with pyrexia of unknown origin. Omalizumab is for type 2. So please remember these drugs like omalizumab, which is anti-immunoglobulin G, right? Anti-IgE monoclonal antibody. Then mepolizumab, reslizumab, benralizumab. These are all anti-monoclonal, anti-IgE, anti-IL-5 monoclonal antibodies. And then we have a dupilumab, which is monoclonal antibody against interleukin 4 receptor. These are anti-interleukin 5 monoclonal antibody, and benralizumab is anti-interleukin 5 receptor monoclonal antibody. All of these are for type 2 asthma only. They are not useful for non-type 2. But there is a new drug called as tezepelumab, which is a monoclonal antibody against anti-thymic stromal lymphopoietin or anti-TSLP. This is for both. This can be used for type 2 and non-type 2. This is for both type 2 and non-type 2. Please remember it. I am not getting into the details of pathogenesis of asthma now because the exam is just around the corner. But if you remember tezepelumab for both, then you will be able to deal with these kind of questions. So biological useful for non-type 2, we have only one choice, right? That is tezepelumab. And this is the newest biological available for the treatment of asthma. Means that is the last one to come into the market as of now. Okay, now B lymphocyte stimulant or B-LIS inhibitor used for the treatment of SLE. In last year there was a new drug approved for the treatment of SLE, which inhibits the B lymphocyte stimulant. See, SLE is a type 3 hypersensitivity reaction. So antibody mediated tissue damage happens. Antibodies are produced by B lymphocytes. Right. So if I block the B lymphocyte activity, then antibody production will come down. Several complications of SLE would come down. So there is a class of drug which inhibits a chemical or a substance which is known to stimulate B lymphocyte. So if I cut down the stimulation to B lymphocyte activity would come down. So what is the drug? The drug is called as belimumab. Okay. Apart from that, there is also one more drug for SLE. New drug for SLE. That is the interferon 1 blocker. Anti-interferon 1 monoclonal antibody. It is called as anifrolumab. Okay, so this tezepelumab, anifrolumab and belimumab, I want you to remember. One of them might come out as a MCQ. Okay, next question. JVP waveform that is absent in cardiac tamponade. JVP waveform. See, rituximab is anti-CD20. That will directly block the B lymphocyte. The B-LIS is a substance which stimulates the B lymphocytes. So the blockage of B-LIS is achieved by belimumab. Right. So in patients with cardiac tamponade, please remember in cardiac tamponade, this is the cardia, right? This is the pericardium. There is too much fluid in the pericardium, too much to the point that when atria fills the ventricle, there are two phases, right? The first phase of filling is where we call it as passive filling. And after that, atria actively contracts and pushes the remaining blood. But because there is too much of fluid in the pericardium, the ventricle will be in a collapsed state and there is no passive filling in a patient with cardiac tamponade. And passive filling on the JVP is represented by Y wave. So if no passive filling happening, there will be no Y wave. So in cardiac tamponade, Y wave will be absent. Y wave or Y descent will be absent in patients with cardiac tamponade. Okay. Last point, what is the best investigation to differentiate between the acute kidney injury because of pre-renal cause and acute kidney injury because of the renal cause, which is acute tubular necrosis? Right, Yogesh Rathi, absolutely right. There will be absent Y descent in patients with cardiac tamponade. Best investigation to differentiate between pre-renal AKI and acute tubular necrosis. The basic point is, what is the most common reason for pre-renal AKI? Kidney hypoperfusion. Sufficient blood is not coming to kidney, so kidneys are not able to do the filtration process. In the acute tubular necrosis, the renal tubules, that is PCT, DCT, collecting ducts, they are damaged. Right? So if sufficient blood does not come to kidney, kidneys they are not able to filter well, so their function is getting disturbed. In such cases, kidneys tries to conserve more water. So we excrete concentrated urine. In acute tubular necrosis, please remember the reabsorption of water happens in the tubules. So if the tubules are damaged, we are not able to reabsorb the water. So we excrete dilute urine. So that helps you to kind of differentiate between pre-renal AKI. See, if you're dehydrated, in hypotension, you pass concentrated urine, right? If you don't drink water from morning to evening urine will be very dark because your kidneys are trying to reabsorb most of the water and excrete concentrated urine. That is what you will see in pre-renal AKI. In acute tubular necrosis, you may even have polyuria and you will excrete dilute urine. Okay, but the most important investigation that will help us to differentiate between pre-renal AKI and acute tubular necrosis is fractional excretion of sodium. See, if the kidneys are underperfused or BP is low, should I reabsorb more sodium or excrete more sodium? Absolutely right, FENA. So if I am in hypotension, that is the most common reason for pre-renal AKI. Should I reabsorb more sodium or excrete more sodium? Obviously, I will reabsorb more sodium and excrete less, right? So when fractional excretion of sodium is less than 1%, means I'm not excreting much, I'm reabsorbing as much as possible, it indicates that we have pre-renal AKI. But reabsorption happens in the tubules. So if tubules are damaged, I will not be able to reabsorb. So I will excrete more sodium in the urine. So when it is more than 2%, it indicates acute tubular necrosis, right? So on this 10 kadam, that's it. If you have specific any other topics that needs to be covered or you have difficulties, you can ping me on the Telegram, and whenever I find time, we will have a quick catch up on either Telegram or the YouTube, and we will address those points. I will share these notes on the PW Med Telegram channel, and it should be available soon. Okay, so for the myasthenia gravis, the most specific test is the anti-acetylcholine receptor antibody. Okay, and the most sensitive test is single fiber myography or electromyography. SFEMG is the most sensitive test, and the most specific test is the anti-acetylcholine receptor antibody. Most routinely performed test is the repetitive nerve stimulation test. Okay, so that's it. Renal tubular acidosis, I will share a quick note on the Telegram soon. Okay, see you tomorrow, guys. Till then, have a good time. Keep studying. The exam is just around the corner. As long as you keep calm, you will be able to sail through it. See you soon, guys. Bye.